today in this IC. Our topic of IC, you must be knowing that don't be stumped by the periocular lumps and bumps. The name suggests that there are any lumps and bumps surrounding the eyelids we will cover, but mostly we are going to cover the eyelid lesions. So our first speaker, we have a galaxy of oculoplasty surgeons from different parts of country. Our first speaker is Dr. Sripurna Ghosh. Sripurna is an RMO in an NRS Medical College, a government medical college of West Bengal. Sripurna, please come.
Welcome to Kolkata. Hope we have a great academic feast over here. I will be speaking on the anatomy pertinent to the lumps and bumps of the eyelid. I have no financial disclosures. Now coming to the anatomy, the lid consists of the anterior, middle and the posterior lamella, the skin, the orbicularis, the tarsal plate and the conjunctiva. And again has the epidermis and the deep dermis. The deep dermis harbors the neurovascular tissue, the hair follicle, the apocrine and the eccrine glands as well as the sebaceous glands. Now coming to the primary lesions of the skin. Firstly, we know a macule is a flat lesion measuring less than 0.5 centimeter. Anything more than 0.5 centimeter or 1 centimeter will be a patch, but it won't be raised. Now coming to a papule, it is a solid elevation less than 0.5 centimeter. Anything more than 0.5 centimeter is a plaque, but it does not have much of depth. Now coming to the nodule, it is a solid elevation with a greater depth. Now coming to the tumor, tumor is a large nodule or a swelling which may be benign in nature or malignant. Now what are lumps and bumps? These terms has been used interchangeably in various literature, but what I understood from that is that a lump is a swelling within the tissue, and when it is causing an elevation in the skin, it is a bump. So whenever we see a lump or a bump on the eyelid, we must inquire about the duration and the progression of the disease. Now coming to inspection, the site of the lesion must be noted carefully, preferably with a diagram, the size of the lesion in all the 3 dimensions, the shape of the lesion, the surface whether it's irregular or smooth, the surface pigmentation, the loss of lashes, any surface ulceration, the overlying skin, and the loss of lid architecture, as well as the regional lymph nodes. Now coming to palpation, the consistency of the mass, whether it's soft, firm or hard, the localized tenderness or temperature must be taken note of. Transillumination must be done in case of cystic lesions. The mobility and the fixity of the lesion either to the deeper tissues or to the superficial tissues must be taken note of. Finger insinuation must be done where in case of lacrimal masses or orbital masses. Now reducibility must be done in case of lid masses. Now coming to the appendageal lesions, this lesion that we see here, it is basically a comedone. It is caused by blockage of the dilated hair follicles with keratin plugs. This small lesion is a syringioma. It is a tumor of the eccrine gland. This lesion is a xanthelasma. We see a papule over here. It is caused by histiocytes which are laden with lipid, and it lies in the dermis. Now the 4th lesion basically here, it is the milia. It occurs in crops and presents as multiple papules. Now these are eyelid bumps which are smooth in structure, rounded or ovoid. They are fixed to the tarsal plate, and on eversion we can see the yellowish tinge. So these are basically chalasia. Now coming to the lid margin lesion, this is the marginal chalasia. As we evert the lid, we can see the yellowish tinge. This is the cyst of mole occurring at the anterior lid margin. This was a unique case. These excrescences that we see are basically dystrophic calcification. This patient was a case of tumoral calcinosis. Now coming to the pigmented lesions. When we see a pigmented lesion, the variability of the pigmentation must be noted. Any abnormal vasculature and localized erythema must be taken note of. These lesions, which are basically seborrheic keratosis, they may have a look of the stuck-on appearance or may have this verrucous type look. Now coming to cystic swellings, the first swelling that we see here is of a epidermal inclusion cyst. It is rounded ovoid. The second lesion is of a cyst of mole. The third lesion, extremely on the right, extreme right, is basically a eccrine hydrocystoma. It presented as a medial canthal swelling or a medial canthal lid mass. And the fourth lesion is basically a sebaceous cyst. Whenever we see a cystic swelling, we must go for transformation test. Now coming to the diffuse lid masses, these lid masses have a bag of worm feel and they form the S-shaped upper eyelid deformity. So these are basically neurofibromatosis. Now coming to the soft tissue swellings, a soft tissue swelling in the lower eyelid or the upper eyelid may be due to an underlying conjunctival cyst causing a lid bump, or it may be due to steatoperiferon in the lower eyelid or the upper eyelid. For the lower eyelid, whether it's fat or fluid, we can rule it out by asking the patient to look up. Fat disappears but the fluid remains. Now coming to the periocular lumps, these children have history since birth of these swelling which are fixed to the deeper periosteal tissue. So these are dermoid cysts. Now this was a cyst in a young boy with history of 1 year, which was soft in nature and not fixed to the superficial or the deeper tissue. So this was basically a lipoma. This was a unique case. This boy had recurrent swelling in the lateral orbital region. It was hard on palpation, and on histopathology we found it to be a chondromyxoid tumor. Now coming to the vascular lesions, they can cause lid bumps as well as facial bumps. They may be an arteriovenous malformation which will have the bruit and pulsation, or they may be in the form of varices which will be positive on Valsalva maneuver. Now coming to the ominous lesions, the ominous lesions have the variegated appearance, variability of pigmentation, there is loss of lid architecture or the lid margin. It may be presenting as a cutaneous horn. They may have a surface ulceration and a surrounding everting edge. Or in case of SGC or sebaceous gland carcinoma, they may present as recurrent blepharitis. Thank you.
Thank you, Dr. Sripurna. That was really a very excellent talk, a very lucid talk, I should say. Then myself, Dr. Chandana Chakraborti from AIOC Kolkata, I am going to talk about periocular benign lumps and bumps. Benign eyelid lesions, it can be inflammatory, infectious, traumatic, or neoplastic in origin. Dr. Sripurna has given a description about that. They are a common condition that requires differentiation from malignant and pre-malignant lesions. Management options are various, like you can just observation, biopsy, excision, injection, steroid, topical application of steroids, antibiotics, antimicrobials, and oral antibiotics. So coming to the first case scenario, we are going to make it an interactive session. If please from the audience, somebody can say. This is an whitish nodular lesion close to the canthus. So what is this? This is a sebaceous cyst. These are obstruction of the gyrus or meibomian gland seen around the eyelid. We have to differentiate it from the epidermal inclusion cyst. Surgical excision can be done, or if the patient is not much concerned, you can leave it also like that. Basically cosmetic purpose, sometimes we do surgery. What is this one? This is also a firm lesion close to the canthus. And there are some vessels are there, but mostly they are not very dilated or tortuous. These lesions, I'll give you clue, congenital or acquired. Prior trauma may or may not be there. They block the orifices of the hair follicle. Slow growing, elevated, round, smooth, white lesion. They do not transilluminate. Can have a central pore. And they can become secondarily infected or rupture. So this was the lesion, epidermal inclusion cyst. Very commonly we come across this type of lesion. What is this? This looks like an calazion, elderly age group, fixed to the tarsus. It has crossed the tarsal border, goes above. We know that if some lesion crosses the tarsal border, then it could be a malignant lesion. So I also thought that it was a firm mass. But no, it was not. And this was an epidermal cyst of tarsal plate. Rarely this type of lesion you can come across. These are keratin fill masses. Two scenarios are given. So what it could be? Sri Purna is the only junior person I can ask. Sri Purna? Yes, this differential diagnosis will be keratoacanthema. But look at the age group. A kala bindi, you can see the kala bindi. Can I get a pointer? Laser light, can I get it? So this kala bindi means it is a child. So child keratoacanthoma in a child, we don't really expect it. So what it could be? So you want to get some other view? Yes, you must see the whole body and the face. So this is molluscum contagiosum. These are caused by pox virus. This is too large actually, too large. But yes, sometimes you can get it. They have gotten, means they first proliferate, then they ulcerate, then they gradually resolves. So if it is a very small, we don't really treat them, but it's a very large, then you may have to treat it either by chemicals like a trichloroacetic acid or imiquimod, or like a lesion like this, you may have to go for excision or cryotherapy. But most of the time they spontaneously resolves. The problem is that they produces follicular conjunctivitis that you have to treat, and the secondary bacterial infection that you have to manage. So what are these? This look like grapes, no? It's like grapes. Apocrine hydrocystoma. This cyst of mole. There are other cysts also which may arise, acrine hydrocystoma. But remember that apocrine hydrocystoma is more common, acris is rarely seen. They transilluminate most of the time, but they may not transilluminate if there is hemorrhage inside it. So in that time, it can look like a bluish tinge. This Tripurna has already described. These are all pictures of neurofibroma. Though sometimes you may confuse it, but look at the surrounding pigmented lesions. And this one actually I missed, the lower one. This one I thought this maybe some other lesions, sebaceous cyst or something. But to my surprise, it came as neurofibroma. So isolated neurofibroma is very rare. This is all of you must have come across this type of lesion. The CT picture, clinical diagnosis is enough, but the CT picture also will give you a clue whether it is an dermoid or something else. This is so soft and the location is that many times we don't treat it, but if a lesion like this you come across, then we have to treat it. One is that they actually resolve spontaneously in course of time. These are capillary hemangioma. They appear, it could be either congenital or it could be infantile variety. 30% of them regresses by 3 years. 75 to 80% regress by 7 years. Treatment usually, look at this patient. We started the patient with propranolol. 1 year propranolol reduced a bit of the lesion, but not the whole one. Then we gave 2 injections of intralesional Kenacort. Now it has reduced. Another case, this is also quite obvious what we are dealing with. This is also a case of capillary hemangioma. The color, this intralesional injection we are giving, intralesional Kenacort. You can see the method how we do it. This is a capillary hemangioma. After giving the injection, 2 injection. After giving 2 injection, the condition resolved almost, you can see. But the problem of this type of lesion is that they produces hypopigmentation. Like this is a separate case in children where we injected this intralesional Kenacort. The hypopigmentation, it takes a lot, I think almost 1 year it will take to resolve. That is cosmetically disfiguring maybe. What is this? This is a 36-year male who came with a round swelling, looks like bluish, firm swelling, not so soft, but you can see the transillumination is positive. Look at the location at the eyebrow. And it comes like pilometricoma. From the hair follicle it arises. These are very rare though, but sometimes you may come across this type of the lesion. Another case, almost like the same type of lesion, but it has got tuft of one or multiple hair can be there on the surface. They don't transilluminate. This is a case of trichofolliculoma. Pilosebaceous, these are hematoma of the pilosebaceous follicle. This is everyone knows is xanthosema. I'm not going to discuss xanthosema. You can treat it of it or you may not treat it. Kosturi will definitely treat it with laser or cosmetic surgery. But I'll show you some other cases. What are these lesions? The histopathology from the, this one came as only the necrosis. No toton cells is found. Fourth. That is actually eye diagnosis as a case of xanthoma necrobiotica. Uporala. This patient without any treatment, the lesion just reduced without any treatment. No treatment. Necrobiotica is the malignant one. Please, can we get that microphone, please? Hand piece. No cells. No. I specifically told them that this is my diagnosis, please find it. They didn't find anything. So this is already Sripurna has described. I'm not going to talk about these lesions. Yes, these are very common lesions actually. They occur in the middle age, different types of looks. They, some people, they say there is no need of taking it out. Cosmetic indication, or sometimes if they produce irritation, then these are all various types of squamous papilloma. This is also the stuck-on appearance. They are not vascular. They are ugly looking. That is the main problem with this type of the lesion. The seborrheic keratosis, cerebri-like surface. This is another one, horn. In this case, we have to be a bit careful because this type of, they are, sometimes they may turn to a malignant lesion. So while taking the biopsy, the base of the lesion should be taken. What is this lesion? See, after 1 week of the diagnosis, this patient came with this picture. So now this is pyogenic granuloma. They actually grow very fast. Within 3 weeks, 3 weeks to maximum 1 month. And this is hemorrhagic. That is the diagnostic clue. But otherwise, this trauma and all, usually most of the time they don't give history of trauma. But yes, there may be trauma histories there. Another lesion. This I really couldn't diagnose initially. Only after doing the histopath, then the diagnosis came. Sripurna, any guess what is this lesion? We thought it could be a papilloma, Kaposi sarcoma, cavernous hemangioma, all those things. But to our surprise, it was a case of pyogenic granuloma again. So these are my references. I have some spotters that we will show subsequently. So I will call Dr. Anirban Bhaduri from Shushrut Eye Foundation. Anirban Bhaduri is a great oculoplastic surgeon in West Bengal.
Thank you. Good morning, everybody. And it's nice to have an audience of doctors who are interested in eyelid tumors. So what we are going to do you've already seen pictures which you're going to see again and again because we want to drive in the point. We actually learn by repetition. And it's all about pattern recognition. So this is what we're going to try to emphasize during the time of this course. Okay, the thing is that what is good and what is bad? I mean, you've seen these pictures before. Dr. Shipurna has shown them. Chandana madam has shown them. And so which of these you think is good and which of these are bad? There are 4 pictures to choose from. You can speak out loud. Second and the fourth, you're faculty, you're not allowed to speak. Anybody else? You can all come forward. This is a very informal meeting. So 4 pictures, which of them do you think are good and which of them are bad? Speak out loud. Okay. Yes, the other thing is now tell me why are these good and why are these bad? Okay. You know what? We should exchange places. Because exactly, that is what it is about. So one of the hallmarks is loss of lashes. See, what happens with malignant tumors is they attack the hair follicles and destroy them. So that leads to loss of lashes. If you see the picture here, you have the diagnosis. It's a lid margin lesion. There is hardly any pigmentation and there is distortion of lashes. So there are hypertrophic lashes growing in abnormal directions, but there is no loss of lashes. This is a classic marginal nevus. Okay? As opposed to these situations where there is loss of lashes. So that is the first point. Sorry. Okay, then you have abnormal blood vessels. So benign lesions do not have abnormal blood vessels on the surface. They would have normal blood vessels or prominent blood vessels just because they've been pushed forwards, right? As you already pointed out, ulceration, very good point. Okay, And then, of course, your first point, which was thickening or the distortion of the eyelid margin. So that is what you see in all these lesions. Now, suppose you had a basal cell carcinoma here, that would not cause destruction of the lid margin. It would not cause vision loss, loss of lashes. But then what else would help you to diagnose? We'll keep coming across that. So these are again benign lesions. You've been seeing benign lesions. These are all cystic lesions of the eyelid. Okay. So they may or may not transilluminate. So this one, for example, pilar cyst or a sebaceous cyst is not going to transilluminate because the content is sebaceous material. This is not going to transilluminate. Okay, but the others may. This, madam has already shown tarsal cyst. Tarsal cyst is something that is often confused as a chalazion and are often operated as a chalazion, and they always come back. Okay, these are lesions that you need to excise from the anterior surface. And they always have a footprint on the tarsal plate. You might have to sacrifice a part of that tarsal plate. Okay. Now we'll come to solid masses. You again been seeing these masses. Okay. What is this? Okay, let's start with the first one. What is this? Madam described it. Cerebriform surface. Sometimes they're very dirty looking, stuck on. So this is the severe keratosis. It's called cerebriform because it looks like the kernel of a walnut or your brain, right? This, what is this? This is a child. Multiple lesions. Yes, this is also molluscum. So molluscum classically is described as having an umbilication, but it does not happen in the early phase. Okay? And what is important is the redness of the eye. You will find follicular conjunctivitis. Okay? You need to excise these, otherwise that conjunctivitis is not going to resolve. All right. This is very simple, sputter. Cavernous hemangioma. This again is a nevus. Okay, just because they're not pigmented does not mean that they are not nevi. This one had me stumped. I actually went ahead and did an incisional biopsy for this. Can you guess what it is? It's a chalazion. Yeah, it's the size that confounds you, but it's a chalazion. And this dirty, ugly looking thing here is again a seborrheic keratosis. But in all of these things, if I lift up that lesion, you will find that it's pedunculated. The lid margin is not affected. Okay, so none of these is the lid margin damaged or destroyed. The other thing is, what is the commonest eyelid malignancy? Basal cell carcinoma, right? Where did you read that? No, wait. This is important. Where did you read that? Because that's exactly what all of us read and grew up with. Basal cell carcinoma is around 90% of all eyelid malignancies. But that is Western literature. Okay, what is the second most common malignancy? The second most common malignancy in the West is actually squamous cell carcinoma. Sebaceous gland carcinoma is a rare tumor. Now these are a selection of studies from India. These are all hospital-based case series, and you will find that basal cell carcinoma and sebaceous gland carcinoma are neck and neck. In some, you will find that sebaceous gland carcinoma is actually slightly higher. In others, you will find that basal cell carcinoma and sebaceous gland carcinoma are actually almost the same. So that is the scenario in India. Okay, basal cell carcinoma is less common in our country as compared to sebaceous gland carcinoma in the West. Okay, squamous cell carcinomas are again very rare in India. In all of these series. But if you look at statistics from further north, so if you look at Nepal you would find in the higher reaches, squamous cell carcinoma again gains prominence. Okay. This is all stuff that you know. We are just revising. Look at this lesion. Part of it is pigmented, part of it is not. It's got a nice, smooth, shining surface. Right? Yes? I again request you, please come forward. We can interact better. And please don't be afraid of making mistakes. That is the entire point of an instruction course, because we want all of us to learn from each other. Okay? So what do you think is this? There is pigmentation. Okay, look at the eyelashes. Therefore, so you made the diagnosis. Therefore, it is a BCC, right? Okay. This is another one. ulceration and the margins, indurated, rolled out margins. So you're right, this is also a basal cell carcinoma. So the others are all going to be basal cell carcinomas. This is what we see. Again, a nodular ulcerative lesion here, okay, with pigmentation. Pigmentation is actually fairly common in basal cell carcinoma among our population. Now this is a variant of basal cell carcinoma. Okay, this is the morphia form or the sclerosing type of basal cell carcinoma. This is a problem. See, I have marked out the margins. This is a 4 millimeter margin that's been marked out for excision. Here, you really don't know how far this tumor extends in the deeper tissues. All right, how much time do I have left?
1 minute.
1 minute, okay. Rush. Okay. Diagnosis. Will this make it easier? So it's a lesion which is mostly in the inside of the eyelid. It has a nodular component and it's got a flat component. Okay. What is the color? Like a basal cell carcinoma. Yes or no? Look at the color. This is also mostly nodular, little bit of ulceration arising from the lateral canthus. So look at the color. The color is important. The yellow tells you that there is oil, okay, or fat. And these are all sebaceous gland carcinomas. And they can be as extensive as this, both the upper and the lower lids involved, the entire conjunctival surface is involved. There are yellow nodules all across. And this is one variant, which is only the pagetoid or diffuse variant, where you do not have any mass lesion. You can have keratin present on the surface. These patients often present as a unilateral blepharoconjunctivitis. So any time you see a unilateral blepharoconjunctivitis which has been treated by our colleagues with topical steroids, with ointments, always do a biopsy. Okay, these are sebaceous gland carcinomas in disguise. This is the rarer of the tumors in India. Squamous cell carcinomas, typically described as having redness and scaling. There can be fissuring and ulceration, but they don't look like the basal cell carcinomas, right? This was an adenosquamous carcinoma, which is a variant of squamous cell carcinoma, very aggressive tumor. And this is what? Volcano-like lesion, central crater. That's a keratocanthoma. Okay. Now, keratocanthoma can actually be a squamous cell carcinoma in disguise. So always biopsy them and then treat accordingly. Thank you. I'll stop here.
Thank you, Dr. Anirban. Our next speaker is Dr. Ferooj. I think she doesn't need any introduction. She is a great oculoplastic surgeon, currently working in her specialty eye care in Bangalore. And she is also a member of scientific committee or India Ophthalmological Society. So, Dr. Ferooj, please. Here.
Hi everyone, good morning. Thank you Dr. Chandana for having me here. It's a pleasure and honor, and this is my first presentation in AIOC. Amazing cases on eyelid lesions and eyelid masses. So what I'm going to talk to you here today is a very interesting topic that ma'am thought about. Tissue is an issue. All right. What do you think when she thought about why should tissue be an issue in eyelid tumors? Is it an issue? Yeah, so that means histopath is very important, right? Histopath is very important in many aspects in eyelid tumors. In fact, tissue should not be an issue. We should get enough tissue because eyelid lesions, unlike like small conjunctival lesions, you get enough tissues, right? But as a practicing ocular oncologist, as an oculoplastic surgeon, what we should make sure is that there is no recurrence in these lesions, and for that, one, diagnosis. Second, it's also therapeutic, right? Tissue is therapeutic, and that's exactly what I'm going to speak today. These are my affiliations and my financial disclosure. I'm going to take you through a story, all right? This is a case, a 64-year-old patient, okay? She presented, she said, I feel a lump, and she was being treated as chalazion elsewhere. Now, when you see this picture, Even me, I don't know which eye it is, whether it's right eye or left eye. I told her, okay, do you want to look down? Maybe some bumpiness is there in the eyelid. Nothing at all. She said it's in the left eye. Okay. I'm like, okay, fine. She's like, I'm feeling slightly better, but there was a swelling and she's been treated as chalazion by a general ophthalmologist. Well, voila. So it's so very important always to avert the eyelid. Okay, so on aversion of the eyelid, this is a lesion which is very plaque-like, flat, yellowish in color, lot of vascularity. You can see that this tumor, there is extension, invasiveness into the margin. Okay, although there is no lash loss over there. Well, very, very, very typical of a sebaceous gland carcinoma. All right, yeah. So now what do I go? I go ahead thinking that I should get a clear margin. So that is why tissue is so very important. Okay. Now I went ahead with wide margin eyelid excision under frozen section control, and that is what I do in my practice. We'll discuss about that. Okay, so usually in my practice what I do, and this is mainly posterior lamellar, right? Anterior lamellar is absolutely fine in this. So I went 4 millimeters on either side. Okay. And after the first frozen section, in fact, I send in the frozen section, although this is kind of a very diffuse and plaquic, there is no congestion even over here. I got a positive margin here. I got a positive margin again, medially. So that is why tissue is so very important. If I would not have done a frozen section, if I would not have checked, whether there is positive or negativity, although clinically it looks, amazingly fine, this patient would have recurred. Okay, and almost, this much of the eyelid is gone now. Recurrence, dealing with the recurrence is so very difficult. So very important to identify that the margins are negative before you reconstruct in any malignancy. Whereas sebaceous gland carcinoma is more of a bad malignancy, lethal malignancy. Okay, we have malignant tumors like Dr. Anirban told about basal cell carcinoma, squamous cell carcinoma, sweat gland carcinoma, but there are 3 lethal malignancies of the eyelid. Okay, I would go according to the chronological order of severity. Merkel cell carcinoma is the worst, followed by melanoma of the eyelid, and third is sebaceous gland carcinoma. And why? Because regional lymph node metastasis and systemic metastasis is high. Okay, so well, I went ahead again, excising. In fact, a lateral margin was excised, reconstructed upper lid with a flap from the lateral canthal, relaxation. And this is how she is. I just saw her recently, follow up 18 months. She was fine. PET scan was within normal limits. Now, basal cell carcinoma, we all know that we saw it can be really diffuse. We call it like a rodent ulcer, right? There is a lot of extension. Although you feel that the margins are well defined, it can extend and extend. And this is one of the case where I had excised twice. One frozen section positive, second frozen section positive. And finally, from here, this patient landed up, losing the entire eyelid. So tissue is so very important for us. So the options that we have is frozen section, or empirical excision. Now, well, some people say we don't have the facility, so how do we send it for frozen section? Let's do empirical excision, just clinically. So that's why I highlighted those 2 cases over there. So when you don't have a frozen section, okay, these are the indications. What I would suggest, so this is why frozen section is very, very important, because what you see is just probably the tip of the iceberg, because it's invasive, it's like crab-like. You may have tentacles of this malignant cells going deep inside into the margin, but clinically this might be the margin, but this would be pathological margin. And that's why so important it is. Now, another option is the Mohs micrographic surgery. In my practice, I don't have a Mohs surgeon. I'm not a Mohs surgeon, so I don't do Mohs surgery. But in the United States of America, there's a lot of Mohs surgeons who does Mohs surgery also. Now, what would I suggest? I understand I have studied in a government medical college as a postgraduate. We don't have all the facility to send for the frozen section. If you are running your own practice, I run my own practice. I don't have a pathology in-house. Okay, so but still I make sure I send my specimen to a pathologist who's sitting in another lab somewhere in another institute, and still I do it. So that is one option. If not, you can go for a wide margin excision. There is no hurry in closure. Okay, you can send it to a pathologist in your institute, expedite it. Just call them and keep asking. 2 days, 3 days. Can you just give me the report? Don't close it. But once after you get the fix-it section report that your margin is fine, then please close it. So that is the third option. So tissue is very, very important. I'm just going to take you through this video how we take the tissue for any eyelid tumor. This is a very typical sebaceous gland carcinoma. Clinically, we identify the margins, okay, in the operating table. So this is basically the margin, and from the margin, we take 4 millimeters. All right. Now 4 millimeters medial, lateral, inferior. Most importantly, sebaceous gland carcinoma especially is a posterior lamellar tumor. So you have to have 4 millimeters posterior lamellar also, just not anterior lamellar. All right. And then you mark it. Sometimes you might have to compromise puncta. You can try to retain it if at all possible. Now then traction is given. Okay. Traction everywhere, and then wherever the marking is, you excise it, okay, anterior lamella and the margin. So this is how it includes the margin, the posterior lamella and the anterior lamella, and then you put it in a filter paper, mark it, and then send it to the pathologist immediately, and then the pathologist tells you. Yeah, so this is reconstruction. I'm not going to go through that. All right, so these are how the margins are taken. With the marking, it's very, very important, and this is how a fresh sample is wrapped in a saline gauze. No formalin, just wrap in a saline gauze, put it, mark it, stitch it if you think it is wobbly, and then send it to the pathologist. All right, yeah. So we wait it out. Initially I do it under local anesthesia, and if I need a big reconstruction, then I do it under general anesthesia in the second procedure. So the patient is waiting in the ward, and this is how it looks. So even a larger excision, you can get very good reconstruction. Now, why is it so important? I'm just taking you through a few cases. This was an empirical excision without margin clearance. The patient recurred after 3 months. All right. Second case, this patient recurrence post-empirical excision biopsy without margin clearance twice. So this is the third time that the patient came with me. She was referred finally after 2 recurrences, like, kindly handle this, okay? But it was all empirical excision. Now, this is a bad case, empirical excision biopsy without margin clearance. When he came to me, recurrence 2 times, 1 month and 3 months, and this is what he had. A large tumor. In fact, I excised it. It came as poorly differentiated carcinoma, possibly granular origin. So there is a sebaceous gland carcinoma which can become aggressive after recurrence into a poorly differentiated carcinoma, where the chances of systemic metastasis, regional metastasis is much, much higher. Well, in fact, we could get a clear margin in this. BC, the basal cell carcinoma. Sometimes people cheat on basal cell carcinoma thinking, well, it's not too lethal, so let's kind of not do a margin and it's going to be fine. But this was a small lesion. Still it recurred in her. All right. And then she had to go for further excision. Now, this was a patient who had a cystic lesion where she was punctured. She said that doctor used a needle because it was cyst, punctured, and then but it grew back again. Okay, now you know what it came out to be? Endocrine mucin producing sweat gland carcinoma. You see this large blood vessels, as Dr. Anirban showed you, all the features to differentiate between benign and malignant. If there is a minimum suspicion of malignancy, make sure that tissue is not an issue for you. You have to go take the tissue from there and make it sure that you diagnose it. Okay, so again I went for 4 millimeters excision, and this is how she is. So our frozen section control, mandated, yes, we did a study, and that is how we always fear of recurrence. So in that, what we found that margin involvement had larger rate of recurrence. Okay, so this is how where it was performed and not performed, 37%. Literature review also says the same. Now, map biopsy, again in eyelid malignancy, especially sebaceous gland carcinoma, is very, very important. And yeah, neoadjuvant chemotherapy is given to chemo reduce the tumor in order to get a good margin during excision. So this is a textbook that I have been part of as an author, which explains the eyelid tumors and stuff. So standard of care in eyelid malignancy has to be excision with histopathological confirmation. Margin status, if it is unknown, avoid closure reconstruction. And very, very important, never do an eyelid sharing procedure if the margins are not proven negative. Okay, thank you so very much. So tissue should not be an issue. Thank you.
Thank you, Dr. Fairouz, for that excellent elaborative talk. Issue. Actually, I thought the title is so catchy, so people at least should come and so.
It's a nice title, ma'am. Thank you.
Our next speaker is Dr. Shima Das. She is an oculoplastic surgeon and ocular oncologist in Delhi, Saraf Charitable Eye Hospital. Dr. Shima, please.
Thank you, Dr. Chandana. Thank you for this opportunity, and it has been, great learning to look at all these interesting cases. So we have already kind of, discussed about the diagnosis, the various mimickers, and how to handle the tissues. So the next part is how to manage these cases. So I'm going to talk in brief about how do you go about managing the patients. So again, when we talk about managing any periocular or eyelid malignancies, we need to know about the type of malignancies, and we have seen already there can be various types. Most commonly, we have the 3 types of malignant eyelid tumors, the BCC, SCC, and the SGC. We need to know the extent of the disease, whether it is just involved or confined to the eyelid, or whether it has gone beyond the confines of the eyelid to the orbit. We need to know the systemic status, so do a good metastatic workup. We also need to know the systemic profile of the patient and whether our intent of our treatment is curative or we are just looking at palliation depending on the extent of the disease. So these are all the things which are going to help us decide how we approach these patients. So again, just to recapitulate, many times when we do a biopsy, sometimes you go for an incision biopsy and sometimes you go for excision biopsy. For example, in scenarios like this, what do you think this is? Dr. Anirban and Dr. Fairuz has already mentioned about, what are the red flag signs. So looking at all the parameters, where do you put it? Do you think it's a benign lesion? Do you think it's borderline malignant, or do you think it's frankly malignant? He's a young guy, couple of months of history. So it looks like a little angry looking vascular lesion. There are some telangiectasia. There is loss of eyelashes. The lid margin seems to be involved. So we lean more towards sort of, malignancy, but we can never be sure. It's a small lesion. Now, if you have to biopsy this lesion, what are you going to do? Are you going to take an incision biopsy to confirm your diagnosis? You are going to excise it completely. You are going to do a shave excision. What should be the plan? Same for the, the second lesion. So in smaller lesion like this, where we know that we are leaning more towards malignancy and we know that this can be easily excised with a margin also, and we can easily reconstruct the eyelids, it's better to go in for a full thickness excision. With presuming that it's a malignancy, you can also take the margin. So this did turn out to be a malignant tumor, apocrine sweat gland carcinoma of the eyelid. And then we could do a direct excision at the first go itself, pentagon excision. So it was just one sitting of surgery for him. So in lesions which looks clinically pretty highly malignant, which are amenable to complete excision without any major surgery, it's best to go for excise. That itself becomes your incision biopsy, and then you go for the histopath. These lesions, Dr. Chandana has already mentioned that the base of the lesion is very important. These are cutaneous horns. Sometimes it might just look like it's a benign looking thing. Especially the first one was actually a small skin tag with some horn, but the second one was not. There is a base to it. So again, in this kind of situation where you feel, again, you're not sure whether it's benign, completely excise it or incise it. Even if you're planning for a debulking sort of lesion without taking any margin, it's important to focus on the base at the histopath. If the base turns out to be malignant, then you have to go back and sort of, excise it completely, taking again 4 millimeter of your margins. Now, these are the 3 most common malignant eyelid tumors, and we know that the primary treatment for all the malignant eyelid tumors of the eyelid remains a complete surgical excision with a margin clearance. Dr. Fairuz has already emphasized on it. I'm not going into the details. 4 millimeter margin is mandatory. If you have a frozen section control, fair enough. Otherwise, you go by clinical margin, assess the margin histopathologically, make sure it's clear before you go ahead and close the defect. And if the defect is small, where it is amenable to close with a direct repair of the lid margin, you go for a pentagon excision and a direct repair. Sometimes it's not possible to close it directly because the patient might be young, the eyelids are not very lax, or the defect is little bigger in size, so you can do a transposition or a local advancement flap. Like here, it was closed with a Tenzel's flap because the defect was slightly bigger. And if the defect is even bigger, especially if it's an upper lid defect, you can go for an eyelid shedding procedure. These are all the procedures which we are going to do after you are sure that you have taken care of the disease and the margins are clear. So this was a cutler beard. If the canthus is involved, which sometimes can be the case, it could be an isolated canthal lesion involving part of the eyelid also. Like this was essentially canthal involving the medial upper and the lower canthus both. And so we know that the canthus is going to be sacrificed here along with the part of the eyelid. So you have to ensure that you reconstruct the canthus also, because these are the pillars for the eyelid, and we have to remember the basic principles for reconstruction of the eyelid. Sometimes we need a combination of flaps depending on whether the anterior lamina itself is involved or it is anterior plus posterior lamina on the canthus. So this was anterior lamina, posterior lamina, as well as part of the lateral canthus. So this was taken care of with an lateral periosteal flap along with a tarsoconjunctival flap for the posterior lamina and a skin graft for the anterior lamina. So there are various combinations which you can use. Like reconstruction is, there is no set rule. It depends on, what you prefer, but all you have to do is to remember the basic principles. First principle is ensure the disease is gone. Second is we ensure that the anterior lamina, posterior lamina is taken care of, and the functional aspect of the eyelid, the lid closure should be adequate, and the movement of the eyelid should be adequate. The corneal protection should be taken care of. So if these are the principles we follow, we can then decide what are the flaps and the grafts which work best in our hand. Medial canthal defect a little tricky to repair. But again, after excision, it's a fairly big defect, almost 2/3 of the upper lid, full thickness gone. So we can do again a combination of flap, a glabellar flap, along with the cutler beard with a local periosteal flap can be used to take care of both the lamina, like this. And again, it's a 2-sitting procedure. You have to divide the flap later on to open up the eyelid. An isolated medial canthal lesion, again, which is essentially involvement of the anterior lamina, you can go ahead and manage with maybe just a excision of the anterior lamina and then covering the defect with a skin graft. Again, ensuring that there is a margin is clear. Now, there are situations where we know the patient needs a surgical excision, but the lesion is so big that these are not amenable to surgery. Now, this was a biopsy-proven sebaceous gland carcinoma which has gone from the eyelid to the orbit, and if you see the extent, it is going right till the posterior orbit. There is no way you can excise this lesion even if you do an exenteration and get a clear margin. So what do we do in those situations? So what we do here is give a neoadjuvant chemotherapy. And we know that it works pretty well in sebaceous gland carcinoma. There are enough evidence now to show that, and sometimes it shrinks the lesion to the extent that you might not be needing a destructive surgery also. Like in this gentleman, we can see the proptosis is gone, almost the lesion is cleared up anteriorly, and many a times it might be possible to just manage it conservatively with some post-op radiation post-chemotherapy also. Again, depends on the residual lesion. So locally advanced HGC, which are not amenable to surgical excision, you can chemoreduce them and then plan your definitive treatment. Sometimes we know that it's a frank malignancy, but if you are planning a destructive surgery, like in this situation, there is no doubt about the diagnosis. But again, just to get a confirmation, because we'll be planning an exenteration for him, you might have to go for an incision biopsy. So other situation where you go for incision biopsy, Dr. Anirban already mentioned about it, the pagetoid variant of sebaceous gland carcinoma, which can present like a diffuse blepharoconjunctivitis without any visible eyelid mass, where you don't know what is the extent of the tumor. And when we do a biopsy here, what we do is something known as MAP biopsy. Why we do a MAP biopsy? Because depending on the extent of the conjunctival involvement, we are going to decide what treatment we are going to offer to the patient. So if the MAP biopsy is positive for say more than 2 to 3 quadrants, we know that we won't be able to excise this lesion and make a kind of functional ocular surface. So in those situations, many a times these are the patients who go for exenteration also. But if it's localized MAP biopsy positive less than 2 quadrants, you can plan for an excision and then reconstruction of the ocular surface, and associated involvement of the eyelid can also be taken care of depending on the extent of the lesion. Now, other situation where we know the patient needs an extensive surgery, it's an eyelid tumor, malignant eyelid tumor, where surgery is the primary treatment modality, but the patient has systemic comorbidity. Like this gentleman, he's an elderly gentleman, more than 80 years. He is on chronic renal failure. His creatinine was more than 5. He's on weekly hemodialysis. He has ascites and multiple other systemic comorbidities. So there is no way the anesthetist is going to give you a fitness for an exenteration, which is a long surgery. But he did need some sort of treatment. You can't give him chemo also. So what are the things you do for these situations? By the way, if you see his eyelid margin is barely visible, the eye is still there. So this is a lesion which has eroded the upper eyelid, gone till the eyebrow and gone till the anterior orbit also. So we had to take up this patient actually under local anesthesia, under some sedation, whatever possible, kept on talking to him, try to do a sort of excision as much as possible with the visible margins, and then reconstruct the eyelid with using a median forehead flap. So idea is there, that you might not have taken care of the whole extent of the disease, but even if you kind of give him longevity for about 2 to 3 years more where the recurrence does not happen, so I think that's what the family was looking at. And if you can add up some post-op adjuvant radiotherapy, that it might even kind of reduce the recurrence rate further. Some other situations where again these are going to be surgical excision, but the surgery is going to be so extensive, it is going to be cause a lot of deformity of the face. The patient is going to lose the eye. So the option here is to sometimes give, post radiation therapy, which we know sometimes for extensive BCC, it works pretty well. It could be a palliative attempt if the tumor has already gone beyond the confines of the face, but more often than not, it works pretty okay. And since it's a very slow growing tumor, the idea is to arrest the growth of the tumor. It can avoid disfiguring surgeries. So just the last bit, sometimes there are situations where you do a biopsy thinking that it's a malignancy, but to our surprise, sometimes it turns out to be something else. So what do you think this could be? It's a very irregular looking thickening of the tarsus, but it's not yellowish, it's more whitish, it's waxy. So does it strike anything? Does it look like anything? So this was a conjunctival amyloidosis, which can mimic sometimes a malignancy. There are hemorrhages sometimes which keeps on happening within the lesion. It can cause thickening of the tarsoconjunctiva. But again, here the biopsy is going to give you the diagnosis. And since these are not malignant, you don't have to do anything about them. And many a times we'll end up with other masquerades, like any guess what the first one could be? On the everted eyelid, it's again yellowish, tarsus is thickened. Do you have anything else in mind? SGC, of course, remains a differential diagnosis, but it was not an SGC. Can you think of anything else here? So this was actually a conjunctival tuberculosis, which was involving the conjunctiva, part of the tarsus. Biopsy proven, it is not a malignant lesion. All you have to do is to treat the tubercular lesion here. The second was actually a patient of Hansen's, the leprosy. He had a periocular swelling, erythema, redness, but it was not again a malignant lesion. So those are the things we have to keep in mind. And in situations like this, where the tumor has gone beyond the confines of the orbit, gone to the pterygopalatine fossa, infratemporal, and this patient also had an intracranial extension, you know that you can't do much. There was a systemic mets also. Essentially, the treatment remains a palliative to give some comfort to the patient. So that was about in a nutshell how we approach this patient. Thank you.
Thank you, Dr. Seema. It was an excellent talk. So our next speaker is Dr. Kasturi Bhattacharya. I don't think she needs any introduction. She is currently, the current position is Kasturi Bhattacharya. The recent award, we must say, Asia Pacific Ocular Plastic and Reconstructive Surgery, upcoming president you are. So congratulations, Kasturi.
Thank you so much. Today, I'm really very happy to speak in this course. Thank you so much, madam, for having me in this course. And more than that, everyone, is it opening? It was working, yeah. So everyone thinks that Kasturi madam always speaks on the aesthetic. But though I do lots of aesthetic, 50% of my practice is also oncology. And really happy to speak about the oncological, experience that I am having over the years. So my topic today is is this moving? Yeah, recent advances in the management of eyelid tumors. And when we look to this global map, what we see that in the Western literature, it is basically the BCC. But what Dr. Anirban had already mentioned, in Asia, we have neck to neck. My voice is gone. Since yesterday, we were so busy from morning 7:30 to night 7:30 with all the sessions. So in India or in Asia, it is basically neck to neck with both BCC and the SCC. So if we really look into the data, the Western and the Asian data shows a very great variation in both the distribution and the presentation. So these are basically the common tumors that we see in the lids, and we all know that eyelid represent approximately 5 to 10% of all the skin cancers, and this is what the percentage which is seen in the Asian countries, as has been reported in multiple literature. So what is the main mechanism of, or what is the concept of this management of eyelid tumors? It is basically the eyelid or the globe sparing to vision sparing. So there has been a paradigm shift towards the vision sparing, and the first line of management, what we say, is basically what all my previous speakers have been mentioning about the wide conservative excision of the eyelid and the orbital tumors and the reconstruction in different ways. And also we'll end up with so many complications when we use the different grafts and the flaps and other tissues. So what is the main concept today? That we go for the targeted therapies, which are the immunotherapies, and today it has become a very viable strategy for management of those tumors which are not being able to be excised, or those tumors which are much in the advanced stage. So if you look here, if we look to the management strategies, I can say this one is surgical and other is the non-surgical. But when we talk about the surgical, there are different concepts to it, as my Dr. Seema has shown so beautifully about the different types of the excision. Feroz has spoken about the frozen and the moss, and also the orbital excision still needs to be done in many patients. But when we do a lead excision, the excision with tumor, we need to follow an algorithm. And because I can see many juniors out here, my very dear fellow, Shipurna is also here, we all follow basically this algorithm where we classify the defect on the basis of the 25% increment, and based on this, whether it's a vertical loss or whether it's a horizontal loss, and based on this is how we go for the reconstruction. So in the very nutshell, reconstruction is basically the reconstruction of the anterior defect, the posterior defect, and the full thickness defect. Anterior defect can be reconstructed very well either with a Z-plasty or with a skin graft, which can be a split thickness or full thickness, and also you let it heal by itself with a laissez-faire. But for the posterior, it is basically a mucous membrane graft, which we basically take either from the lip or sometimes from the buccal mucosa, and also sometimes we need a hard pellet graft. And the full thickness, which we go for the direct closure, or we can go for a lateral advancement, which has been also shown. And this is usually when we have a defect somewhere around 50%, and you have a good amount of laxity of the skin. So these are the situation where we go for the lateral advancement. But if it is a large defect, especially when it is in the upper lid, what we do, we go a full thickness tissue from the lower lid, which we classically call a cutler bed procedure. And then this is very nice way, because you do not need too much of tissue. You can just pull the lower lid tissue, and then we separate it after 6 weeks and go for a very good reconstruction. Like this is one of the sebaceous gland carcinoma that you can see here. A 4 millimeter normal tissue has been excised along with it. But what I want to do, because this is being done by most of the surgeon, you need to reconstruct all the lamellae, whether it's a posterior lamellae, whether it's an anterior lamellae. And the best way of making the posterior lamellae is taking the tarsoconjunctiva from the other lid. So this is a graft, and I am harvesting the tarsoconjunctival graft from the other lid, and this I will use to form the posterior lamellae of my newly reconstructed eyelid. So this is a full thickness tissue that I am taking below the tarsus. I am making the cut. So you are having only the anterior lamella, which is coming from the lower lid. So the posterior lamella will become, and this is what people we have been discussing about the map biopsy, which we usually do for all the sebaceous gland carcinoma. And this is the posterior lamellae that I have been taken from the other lid. But the next important thing, that you need to identify this LPS. This is the aponeurosis, and you need to suture this aponeurosis to the new posterior lamellae, that is the tarsus and the conjunctiva. Otherwise, you might end up either with a lid retraction or sometimes even with a ptosis. So identification of the tissue, and tissue why it is so important, Chandana madam has already mentioned that identification of every tissue during the surgery is very important, and it needs to be placed in the appropriate place even during the reconstruction of every surgery. So this what we do after 6 weeks, we need to separate, and during the separation you should be very careful trying to give as better aesthetic correction as possible. And this are the patient, you can see the post-operative, not a very good picture because I was out of town, and this is the picture taken by my fellow with her phone, and these are some of the patients. I think this was during Shipurna's time, if I'm not mistaken. So these are sometimes which already had been mentioned. This is a pagetoid spread, you end up cutting whole of the lid. So along with, sometimes it's not possible to get the tarsoconjunctiva from the other lid, you can also use tarsus to form the posterior lamellae. And this is some of the patient. This is one of my patient, I kept on cutting, and ultimately I have found the whole lid has been cut. So here you need to take a flap, the flap that has been taken, the Frick's flap that has been taken by the forehead, and also you can see the legophthalmos was not much following the reconstruction. So in the lower lid, classically what we do a Hughes technique. That is what we take the posterior lamellae, the tarsoconjunctiva from the upper lid, bring it down, and the anterior lamellae is reconstructed either with a graft or a mobilization of the skin from the surrounding tissue or with a flap. So this is a Hughes technique that we do, and then we separate it after 6 weeks. Sometimes it is such a big lesion, it is not possible to have only hughes. Then we take a periosteum, and this periosteum also forms a part of your posterior lamellae. And also sometimes we end up doing more major surgery like the mastoides, and also exenteration needs to be done, though we try our best to salvage the globe and the tissue as much as possible, but there is also, it becomes very hopeless in some situation where we do an exenteration. But herein I like to mention that exenteration is not the solution. If you do not fill the cavity with something, it really affects psychologically. Number one, the healing is so difficult. Sometimes you need to keep on cleaning this socket if it is not, or if you just give a split thickness skin graft, sometimes you need to do everyday cleaning at least for 3 to 6 months. So these are the situations what I feel that I like to do a temporalis muscle transfer, because there's a very simple way, because you have this temporalis muscle just by the side of it, you draw, and sometimes I take this vein spike to know exactly where are the vessels, and then accordingly the incision is being placed, and then you incise, take out the temporalis muscle, and this is how the temporalis muscle is being pulled and is used to fill the cavity. And this is what I do for most of the exenteration patient. I have got how many minutes more? 4, 5. Okay, a very brief about what is the recent how many minutes? Recent targeted therapies, and this is what radiotherapy has been already mentioned, but let me mention here what are the targeted therapies. So based on the tumor, like these are the list of the tumors that we have in the lid. One of the most common tumor is the BCC, and the main signaling pathway for the BCC is the hedgehog pathway, and this hedgehog pathway is today considered to be the hallmark of the BCC pathogenesis, which really plays a very important role in number one, embryogenesis, number two, cell differentiation and cell proliferation. And if you look here, it basically targets the smoothen receptor. So this is one of the concepts which works not only for BCC but also the sebaceous gland carcinoma. And then we have for the squamous cell carcinoma the epithelial growth factor, where there is overexpression of the epithelial growth factor leading to the carcinoma. In melanoma and also in Merkel cell tumor, we have either the mTOR pathway or the BRAF pathway. I'll not go much into details, but what you need to remember is the PD1 and the PDLI, which you can see it is involving in most of the tumor, and this really it controls the induction and the maintenance of the immune tolerance within the tumor microenvironment. So this is basically PD is the programmed cell death ligand, and this is a membrane protein which are being expressed in the tumor cells, and this can be detected very well by the immunohistochemistry. So I will not go much, but I'll just mention some of this targeted therapy, especially for the basal cell carcinoma, which we have the vismodegib, and this is basically an inhibitor of the hedgehog pathway. And along with this, now the sonidegib is also available in India, but the problem is that it is much costlier. But I feel that imiquimod, which is much cheaper, and I have also used it in some of the patients, it really gives a good result, especially for the surface tumor, because I feel it is more of an immune response modifier. So this is also a good targeted therapy. The squamous cell carcinoma, which is really very dangerous, and the main pathway is the epithelial growth factor pathway, where there is an activation of the epithelial growth factor with the P53 tumor suppression and the rest oncogene being taken. I think my time is over. Should I stop it here? I just want to show this video how we do a map biopsy. So there are points how you do a map biopsy. You can classically, I think Dr. Seema will agree to us, we usually take the 14 points, but sometimes we end up taking the 15 points. So this is the 3 in the palpebral upper and the lower, 3 in the lid, that it comes to 12, 1 medial lateral limbus which comes to 14, 1 in the caruncle 15, and if you really think in maximum we go for 17, and anything above 4 needs to be exentered. So this is how we keep the tissue. We keep the tissue, and you need to mark it, and you need the reports of all these 14 to 17 points that you take in the map biopsy. So with this, I like to conclude. For the students, you take this, I think you're taking a screenshot, take this, how do we, the American Cancer Society, they take this ABCDE as a very good guideline for the diagnosis of early melanoma, and these are all the immunotherapies for the melanoma, and these are the adjunctive therapies. And now also we need some amount of cosmetic correction, where we do go for a photodynamic therapy or the IPL also in many of the late surgery, but the gold standard today is still the surgical resection with a clear margin. Thank you very much.
Thank you, Dr. Kosturi. That was an elaborative talk on. So as we have crossed our time, I think the other people are waiting, but no IC is finished without any interaction with the audience. So by the time the other session is starting, we'll just have some audience interaction. The other session you can come. So this is.
Ma'am, I think we still have 1 minute time. 9:45 tak is the session.
Okay. This is for audience. This is for audience. So at the end of the instruction course, what do you think? What is this lesion? For the PGs, what is this lesion? This one. You've heard the eyelid. So this is very important. You have to evert the eyelid, then you come to the diagnosis. Synovial and carcinoma. What is this? As the IC suggests, this is lumps and bumps on the periocular area. So what is this lump? Even I got stumped by this lump. What it could be? This was a case of actually lymphoproliferative disorder. Another patient. What it could be? Diffuse thickening of the upper lid. In other eye also there is some conjunctival lesion. What it could be? This is a known case of systemic lymphoma. Now it is in the eyelid also. So I'll just finish it. Okay. Finished. So thank you, audience, for your patience in hearing.